All right. Good morning, good noon, good afternoon. Yet another version of Thursday VMR. I'll be so sad the day that I don't get to say this. But it sounds like I may not be actually sad because I think the day I don't get to say this is the day I probably don't feel any emotions whatsoever for reasons that are self-evident. Um, I'm very, very thrilled today because we have the return of a VMR legend, Moon, who's presenting a case. Maybe Moon, I can hand the mic to you first to update folks on how life is treating you, and then we can introduce everybody else.
Hello, everybody. I'm doing really well with I studied cardiology rotation, and the smart person I'm more in cardiology. I'm so excited because she's so kind and smart. So yeah, I really enjoy her discussion. So and also my teacher Rabih, I'm really excited to hear about your teaching. And Hans and Magnus, thank you so much for doing the teaching point and scribing.
As you guys will see more and more, I don't think Moon has learned the word I. I think very, very rarely does she ever talk about herself. I hope you noticed what she just did, which is gave you a 3-second update and then just put the spotlight on other people, which I think is just so symbolic of your kindness and your philosophy in life and why we all admire you so much. And yes, Anmol is probably way more familiar with your position today, Himun, having presented 100,000 cases on VMR. But today she gets to feel the heat of an unknown case to her. I'll hand the mic to you, Anmol, to share with us how you're feeling. And I don't know how much updating you have to do since you just presented recently, but maybe whatever has been going on in your life this past week.
Okay, so good morning, good afternoon, and good evening to everybody joining us. My name is Anmolpreet, and I will be on the case discussion seat today. I'm an international medical graduate from India. I was here on rotations and will be giving my step 3 before I leave back. And I'm very excited for this opportunity, and I think we see the world according to how we are. So whatever Human said about me being kind and smart, she is that herself. And I'm very excited for her case. So I hope we have a great 1 hour of learning and all of us can get something to reflect upon after this. Thank you.
Well, your philosophy and approach to life is so soothing. I wish I could wake up every day hearing you say good morning, good noon, good evening, good afternoon. Like that would be the best alarm clock possible. And it really sets the stage for the mood for this session. Thank you so much. All right, we have to honor the people who are making this happen, beginning with Magnus, who is scribing. Magnus, I'll hand the mic to you.
Hello, everybody. My name is Magnus. I'm from Denmark, and yeah, I'm always looking forward to Animals discussion. And yeah, a case by Heman today. I'm so excited for it.
And Hans gets to capture all the learning today. Hans, mic to you, my friend.
Yes, thank you very much. I think it's going to be a very exciting case with excellent case discussions. So I'm trying my best to keep up.
Yeah, hey, all we can do in life is try our best and make sure we have fun. As I said to my friends in Japan who might be listening to this, I told them yesterday that they only get to live Wednesday, September 3rd, 2025 once. So I think we'll only get to live this session once. Let's have some fun. All right, Mike, to you, Himon.
Okay, let's get started. Okay, so chief complaint is a 47-year-old woman was admitted with anisocoria and both visual and auditory hallucination. I will end here.
Yeah, Anmol, what an interesting start. I'm curious, what thoughts are you having?
Yes, I think that's a very interesting complaint, and I have not seen this very much explored on the VMR, so it will be interesting to discuss it. When I think about these complaints, the first question I have in mind is the time duration of these symptoms, because if this is something acute, I have to rule out an emergency cause, that is stroke. If it is something within few hours or few seconds, but I think the time course will guide me a lot. And anisocoria, how I define it as it is the difference in the size of both of the pupils. So I think what else can we ask? Maybe we can also ask any history of trauma or any other psychiatric history. Then medication history will be important as well. just so that to elicit some of the important causes that we can rule out just from the history. Other than that, I think both visual and auditory hallucinations with anisocoria. I also, if we just put anisocoria out of the picture and just the hallucinations, then definitely a drug history is also important. You have to consider what the a patient had been abusing since the last day or time, any history of poisoning. But I think thinking about anisocoria will be important, and I don't have very great differential for that. Maybe there could be something compressing one of the orbits in some way, which can lead to difference in the size of the pupils. So there are some of the scattered thoughts that are coming to my mind. But first of all, I would want to know the time duration, and if it is acute, then I would want to know the if it is related to stroke. If I want to rule out that, and I want to rule out the other history as well.
Yeah, absolutely. Excellent analysis. I think it has to be scattered because you're working with so many unusual things, I would say. And there also seem to be connected only with some friction, not so smoothly, you know? And so I will share with you, Anmol, that what I'm itching to hear as we talk more with this patient is there encephalopathy or not? Because visual and auditory hallucinations with encephalopathy reframes the problem as an altered mental status with focal neurological features. If there is no encephalopathy, then there is a strategic dysfunction of the visual and auditory pathways, which is a very different problem. So to give you an example, focusing just on the visuals, if somebody is having visual hallucinations but is telling you very crystal clear that they're having visual hallucinations and not confused, that often actually raises concern for disease along the visual pathway alone, including blindness causing visual hallucinations called Charles Bonnet syndrome, or disease restricted just to the occipital lobe, like occipital lobe seizures. So it's very, very important anytime that you're solving hallucinations to ask yourself, is this with or without encephalopathy? And it's also going to be important to try to figure out what the anisocoria or the pupillary asymmetry means, because it can mean one of three things: a dysregulation with the parasympathetic system, a dysregulation with the sympathetic system, or completely unrelated. So anisocoria is fairly common, especially if patients have had surgery on their pupil, or on their eye, and therefore their pupil, which results in local dysfunction of the local autonomic nervous system, causing pupillary dilation. So it's very, very common for the general population to have had some form of eye surgery in their life. And so the significance of anisocoria is always in the context of a non-surgicalized eye. But Anmol, it's also going to be very important to try to figure out which pupil is the problem, because all that Heemoon has told us is the pupils are of different sizes. Is the small pupil the problem, or is the big pupil the problem, relatively speaking? And the best way to determine that is to put the pupils in extreme conditions of light. So Anmol, let's just do this practice exercise together, not this patient, of course. But in the extreme dark, which pupil do you think is abnormal? The one that is large or the one that is relatively smaller?
The smaller one.
Exactly right. Exactly right. So in the dark, pupil should be dilated, and a constricted pupil is abnormal. So what can you do? You can use light, extreme light, and see what happens to the pupil. And in that context, the exact opposite is true. A pupil that remains dilated in the face of a stimulus of light is abnormal. So we'll have to figure out, has this person received eye surgery? And which pupil is abnormal? Is it the dilated or the smaller one? If it's the smaller pupil that's abnormal, then that pupil is getting too much parasympathetic tone. And either there's too much parasympathetic tone or a deficiency in sympathetic tone. So Horner's deficiency in sympathetic tone causes a small pupil. Alternatively, if the pupil is large, then it's getting too much sympathetic tone, either as a result of sympathetic excess, say from a stimulant like cocaine, or it has a deficiency in parasympathetic tone, say as a result of the compression, as you said, in the orbit of the parasympathetic axis. Now, in general, whenever you're solving pupillary issues, you are trying to figure out, is it too much sympathetic or parasympathetic? As a general rule, whenever you have pupillary asymmetry, you're much more likely to have a deficiency of the sympathetic or parasympathetic system rather than an excess. Excessive parasympathetic activity or excessive sympathetic activity usually causes bilateral pupillary changes. So in a patient who has cholinergic toxicity from too much parasympathetic tone, both pupils are constricted. In a patient who takes cocaine, both pupils are dilated. Anisocoria often represents a focal lesion causing deficiency of either the sympathetic or parasympathetic system, presenting with asymmetric pupils. So here, Anmol, our task will be which pupil is the problem, and whichever pupil is the problem will likely be solving a deficiency of the either sympathetic or parasympathetic system, depending on which abnormality there is. So a lot of work left to do. Let's see where Himun takes us next.
I wish Rabih was there. I wish I did the test. Well, next time I will never forget that. And yeah, so HPI maybe will give you a more answer to your question. The patient with a history of a polysubstance abuse, present with a restlessness, leg discomfort, sweating, and anxiety, and severe hypertension 193/99. And she also report visual and auditory hallucination, describing insects, shadows of people, and voices, in association with nausea, vomiting, constipation, sore throat, rhinorrhea, abdominal pain, and urinary burning. She denies seizure, headache, chest pain. The hallucination resolved within one day. She also noted that she had never previously been aware of her anisocoria. Yeah, I'll end here.
Wonderful. Very, very interesting. So, Anmol, what changed for you? How did this information help you make progress?
Yes, I think your description was very great, and I understood a lot from that. And I just wanted to clarify, what was the duration of the chief complaints? Was it like one day or?
Yeah, so the visual hallucination, like after patient is having restlessness and hypertension, she started to have a visual and hallucination, but it's just appeared just for one day and disappeared.
Okay, thank you very much. So I think the first important history that caught my eyes and ears was polysubstance abuse. That could have definitely led to this presentation, but still, I am not ruling out stroke at any cause, because we have this severe hypertension with which the patient is presenting. And I believe that there is something going on in the body which is leading to this hemodynamic instability. If we see that there is so I think the question here is right now if we are just attributing all the symptoms to drug abuse or the dyselectrolytemia resulting from that, or we are considering the option of the patient having stroke. So I think neurologic examination will be very important too in this case. And I'm not sure if the patient was acutely altered. That is something I'm looking out for. And I think the neurologic examination with the aspect of muscle strength, and if the patient is not altered, then I think that would help as well. I guess we should get an imaging of the brain to rule out that emergency. And about the polysubstance use, I think we should know what are the drugs basically which the patient has been abusing. And if I say the drugs causing unilateral pupillary pupillary dilation or constriction, I think that is something not very much seen, as you said. If we have a cholinergic toxicity due to, for example, organophosphate poisoning, we'll see bilateral changes in the eye. So this unilateral thing also makes me think of something structural there, which might have led to this presentation. But if you ask me the next steps, I would want to know the whole of the drug history and imaging of the brain with the neurologic examination.
Absolutely superb analysis. I have nothing to add to your medical analysis, and I really admire your focus on being more precise about the substances that this patient is using. And I think that it's actually very common for us not to be more precise, because uh, uh, this space gives us a lot of insight into the patient's life in general. And I think the general assumption is that most patients, many people who have to resort to using illicit substances or intoxicating substances to live life often have to do so to be able to cope with adversity and challenges. And the adversity and challenges may be psychiatric, psychological, social in nature, financial in nature. And so I think knowing the precise substance involved gives you a tremendous insight into the range of complications. So, for example, the complications of alcohol use are very, very different than the complications of cocaine use and methamphetamine use. For example, patients who are intoxicated on alcohol are rarely hypertensive. This degree, in stark contrast, methamphetamine and cocaine certainly do so. It's also a great opportunity to just take a moment um, and ask ourselves, why do we commonly use and teach the word polysubstance abuse? And you just made a very good argument, Anmol, that maybe we should try to be more precise about what substances are involved, which I agree with. Just like saying somebody's immunosuppressed. Well, if it's very different, if they're immunosuppressed from diabetes than they are immunosuppressed from HIV. But I think also the word abuse is very interesting because the relationship between the patient and the substance is very, very interesting. Um, when we say polysubstance abuse, very, very commonly, almost universally, we're saying that the patient is abusing the substance, right? But I think it's the exact opposite. I think the substance is abusing the patient, uh, and that the patient's life is in turmoil and often severely exacerbated underlying psychiatric and social issues are made even worse by the substance. So, is it the patient's fault or the substance's fault? And I think the substance really is just symbolizing the patient's hardships in life. And so, um, for me, I always wonder about the words we use in medicine sometimes, and they're pervasive. Heemoon's using it today because I guarantee you every single teacher that she's had has said it. She didn't make this term up. But I encourage all of you to be a little bit more thoughtful about it. What does it symbolize? And here Anmol is already making the argument that we could easily fall into the trap of assuming that a substance is causing the pupillary issues. But we already shared why a substance will cause bilateral, simultaneous pupillary changes, not a difference in the pupillary size. And I think that's going to be really, really key. So it's interesting, Anmol. I think we have a little bit of a dilemma. And the dilemma is, since all of her symptoms washed away in 24 hours, do we still have to think about them? And I think it depends on what substance was used. If the substance that was used was alcohol, these symptoms don't really make sense. But if the substance that was used was a sympathetic stimulant like cocaine or methamphetamine, then these symptoms make perfect sense. In which case, we will probably not have to make more analysis of those symptoms and focus just on the anisocoria. But ultimately, here's the most important rule. Focus on what the patient's chief complaint is. And the patient's chief complaint was all these symptoms, but now she has no concerns except our discovery of the anisocoria. So I'm like you, I'm inclined to focus just on that, attributing these sympathetic activation symptoms, sweating, anxiety, hypertension, nausea, to the possible exposure of substance. But we may have made a misstep. We may have to come back and say, oh no, we still have to think about these things because they're relevant in some way, shape, or form. So yeah, let's see what Heemoon has in store for us and how we can tackle this pupillary issue.
Amazing discussions. Learning so much from you guys. Okay, so the patient is polysubstance are list are opioid, fentanyl, cocaine, methamphetamine, and also past medical history of hypertension, hypothyroidism, and PTSD. Medication was methadone for opioid use disorder, and bupropion, quetiapine, hydroxyzine for the mood and sleep disorder, and levothyroxine for hypothyroidism, and metoprolol for her hypertension. And her social history is homeless, and I don't know whether it's the right way to say it. Homeless, okay. And the health-related behavior is daily heavy alcohol use since age 17, primary hard liquor, and yeah. So yeah, she's been drinking since she was 17, never stopped yeah, drinking. And then yeah, and then because Amor was wondering about CT head, so I will just give you answer right now. The CT was normal, so we were really worried about anisocoria, but I guess it was like physiologic from the like she just did not notice, but I don't think it was really problem. It was just physiologic one. Yeah. And do you want me to keep going or do you want me to stop here? You're Rabih, I cannot hear
Oh,
you.
sorry. Yeah, whatever you have planned, Himon. Do you want us to stop here now or?
Oh, I can give you a physical exam.
Okay, please.
Okay. All right. Vital sign is 36.4. Heart rate is 120. BP is 193/99. Respiratory rate is 20. SpO2 is 99%. In general, anxious, restless, diaphoretic, HENT, a mild sore throat, runny nose, anisocoria, right 4 millimeter and left is 3 millimeter, neurologic, alert, oriented, agitated, tremulous with a tongue and hand tremor. Hallucination was present but not anymore. No focal neurologic deficit. Abdomen, mild periumbilical tenderness, non-distant and no guarding. Respiratory, lung clear to auscultation bilaterally, and cardiac tachycardia, regular rhythm, and no murmurs. Yeah, we'll stop here.
Wonderful. Excellent. Thank you so much. All right, Anmol. A lot of thinking to do. What's your mind doing?
Yes, I think now is the time it's important to understand what problem we are solving. If I say that the patient comes to the emergency when the patient is having these symptoms, because we know after one day that the symptoms resolved. When the patient is coming to the emergency with the symptoms, definitely then imaging of the head would be important. Now, for example, we don't know if the hallucinations were resolved or not. So about the past medical history, the patient is on opioids, cocaine, and methamphetamine. Um, these all can do a lot, and I recently got to know about methamphetamine can actually cause chaos in the body, affecting heart and causing all the bad things that can happen. So that will be definitely in my mind. If we talk about opioid toxicity, then yes, I think the patient comes with respiratory depression and meiosis, bilateral meiosis, if I am not wrong. And I think with cocaine can cause a lot. I've seen cases in VMR only about if the patient is having pre-existing heart disease, cocaine can cause flash pulmonary edema, which can present like hypertension and shortness of breath, acute onset, but that is not the case in this scenario. Since there is so many substances involved and we don't know what she was taking currently, there must be some drug interactions there which has led to this presentation. If we talk about metoprolol, it can lead to bradycardia, but okay, we are seeing I think basically from the vitals, what I can gather is there is excess sympathetic response to whatever culprit that has been in the body, be it drugs or anything else. There is excess sympathetic response. We see diaphoresis. That is also the result of that, and I think we might as well have some urinary symptoms too. Or I'm just thinking about all of that. Mild periumbilical tenderness can represent many things, but can be non-specific to at this point. So I think getting the labs will be important to investigate the periumbilical tenderness, because there is a whole lot of differentials which can look like that. And about the the neurologic examination, we do have the tremors. That can also be due to dyselectrolytemia. So what I am thinking right now is there is excess sympathetic response due to some culprit which we have to identify. And if we talk about drug screen, and I think that you have to tell if I'm saying it right. I think the urine drug screen is the blood drug screen is better. Serum drug screen is better than the urine drug screen. So that is something I am thinking right now, that if there is some toxicity about as pertaining to the drugs. I'm not sure if I got everything, but that's what I'm thinking right now.
Yeah, and well, I think it's amazing how you first started by saying we have to figure out what problem we need to solve. And I think the anisocoria is gone. There's only a 1 millimeter change in both pupils. And so that is really not the center of gravity in this case. And it could be overwhelming to try to figure out what the center of gravity of this case is when the patient is literally having symptoms from head to toe. But your knowledge and reasoning allowed you to see that there's one thing unifying everything, and that is sympathetic excess, tachycardia, hypertension, anxiety, restlessness, diaphoresis, and tremors. You don't need a separate explanation of dyselectrolytemia for a tremor in a patient with sympathetic activity. It alone is a very sufficient explanation for them. And even the auditory and visual hallucinations can be manifestations of excessive sympathetic tone. So I think the question really comes down to, why does this patient have excessive sympathetic tone? Anmol, this is a really key point that you made, but I think you made it subconsciously. So my goal for you is to learn it more clearly, and so you don't make this mistake that I made a few times. So Anmol, if I break my leg, what do you think my heart rate and blood pressure will be?
Will be elevated.
Yeah. Do you think I'll be anxious?
Yes.
Diaphoretic?
Yeah.
Restless?
Yes.
Yeah. What am I trying to get at here? It's very normal to have an excessive sympathetic tone as a result of a focal, severe issue, no matter the nature of the issue. So if somebody has severe urinary retention and pain from a focal issue in the bladder, they present just like this. Whenever somebody has excessive sympathetic tone, it can be very distracting to realize that they have a focal problem that is causing them significant distress, and so their body is reacting to it. This is a very serious dilemma in pediatrics or in patients who are older and in dementia who cannot complain to you or say to you. So the mistake often is the patient has sympathetic excess, so as a result, it must be something that the patient is taking that's causing them to have this response. But the answer actually may be that a patient has a very focal severe problem, which is why it is very, very important to do a comprehensive exam in these patients to try to see, is there focality? And so the question is there focality in this patient? Does she have periumbilical tenderness from mesenteric ischemia, and she is in so much pain that she has a markedly elevated sympathetic? So once you've identified sympathetic toxicity, the key question is there focality or not? And for most people, there isn't. And that triggers the hypothesis of the patient having ingested a sympathomimetic like cocaine or methamphetamine, or is withdrawing from a sedative like alcohol, or instead of one substance accounting for the symptom complex, the patient is having a drug-drug interaction, resulting in serotonin syndrome, neuroleptic malignant syndrome, so on and so forth. So there's a lot of work that needs to happen to figure out, is this a diffuse sympathetic toxicity from the action of specific molecules like cocaine, alcohol, serotonin? Or is this the body's physiological response to a severe crisis in a specific location here in her abdomen? So, Anmol, I'm really curious. This patient is in the emergency right in front of you. You're going to get some diagnostic tests. Are there any treatment modalities that you would dispense to the patient at this juncture of time?
That is a very important question. Okay, so what can we give to the patient? I think definitely the labs would be important, but I believe giving intravenous fluids is something I'm thinking. But I don't understand what else. I have to think about this question. I am not sure.
Oh, wow. Look, I finally found something I can teach you. There's a life-saving medication here, Anmol, and that's benzodiazepines. There is nothing here that's inconsistent with severe alcohol withdrawal and risk for delirium tremens, tremulousness, hallucinations, tachycardia, hypertension. Benzodiazepine is a fantastic medication for sympathetic excess, no matter what the cause. The most morbid causes are alcohol withdrawal and neuroleptic malignant syndrome and serotonin syndrome. And the treatment for all of them is the same thing, benzodiazepines. And the benzodiazepines here may be life-saving from a severe sinister process. But here is the other value of benzodiazepines, Anmol, is if I have broken my leg and you haven't realized that yet because you have been understandably distracted by my tachycardia, hypertension, diaphoresis, if you give me benzos, you will better be able to see where my focal problem is. So the benzodiazepines are a very outstanding medication here, both to treat the more serious causes of diffuse sympathetic toxicity, but also to allow you to dampen the sympathetic excess and see if there is, in fact, a focal problem or not. And I think that will be really, really crucial here. All right, Himoon, what do you have next?
Ravi, you're reading my mind, and Amor, you are doing a really good job. Yeah, so for the history of alcohol use and also the opioid use, the CIWA, the it's always hard to pronounce. CIR score was a 26, alcohol withdrawal or severe, and COW score was a 20, opioid withdrawal moderate. So as Rabi mentioned, we gave IV diazepam, and it was given along with the thiamine, folate, and multivitamin. And since the patient was having a nausea and vomiting, we gave D5NS and labetalol and ondansetron IV for high BP and nausea and vomiting. And I will go with the lab. WBC was 9K, hemoglobin was 12.4, platelet was 210, and sodium was 138, potassium was 3.2, chloride was 102, HU3 was 224, PUN was 16, and creatine was elevated 1.43. Glucose was 112, calcium was 8.6, magnesium was decreased 1.5, AST 88, ALT 44, alkaline phosphatase was 118, T-bilirubin 0.8, albumin 3.6, and TSH and HCG was within normal limit. And also, CT head was normal, chest X-ray was normal, UA was normal, and CT abdomen and pelvis noted a constipation. I will end it here.
Fascinating. Thank you so much, Himoon. All right, Anmol, Mike to you. What are you thinking?
About the starting scores, I don't know if I have much knowledge about that. Maybe it just indicates that there was severe alcohol withdrawal and moderate opioid withdrawal. Oh, and after that, I think the most prominent labs which I see is that CPC is normal, but we have hypokalemia. And acute, likely acute kidney injury because we don't have the baseline. So I'm just trying to understand from the BUNR creatinine ratio what kind of injury this is, but I'll come back to that. And then we have hypomagnesemia. Okay, and after that we have mild acute liver injury that is just mild with AST elevation. And other than that, we have the everything else is normal. So these are the main problems we are solving. So if I start with the liver, and I think it's only the AST which is elevated. When it is only AST elevation, we tend to think of causes other than liver, and it is just a mild elevation. So we might as well think of it just like a manifestation of that other systemic problem. So we will keep it on the side of the eye and not just anchor on this. And then we have acute kidney injury likely. So I'm just trying to see how much would be the BUN or creatinine ratio. I think that would be less than 15 in this case. And that makes me think about the intrarenal causes or something like that. But I'm just trying to think in that way. Other than that, we have hypokalemia. So this is very interesting. Whenever we have hypokalemia, we have to see if it is we are losing it from the gastrointestinal tract or from the kidneys. So currently, we don't have the history if the patient was having any nausea, diarrhea. The patient is not on any diuretics. I think these are the most common causes for hypokalemia. So maybe the patient is just because of that, all the symptoms, maybe the patient is hyperdefecating, or maybe the patient is urinating a lot that is leading to this presentation of hypokalemia. And or if I think when we are solving the problem of hypokalemia and we are not able to localize it to the GI system or the kidneys, I think we can get a pH to understand what is happening in the body, if it is acidosis or alkalosis, and then we can think about the other further causes which can lead to this presentation. So I'm solving hypokalemia in that way. But if the patient comes to me with all these symptoms, I think I would have gotten an ABG to understand if because in my lab the labs come later, so I do get an ABG first. But what to understand from this labs is you can give IV fluids to actually help with the kidney injury, and but then we have to correct the potassium because that can precipitate arrhythmias as well. So maybe the KCl, we can calculate the potassium deficit and give the KCl in fluids. That is what I'm thinking right now.
Your thinking is so clear, so logical, very analytical, and very practical. You have reached the milestone of intern year where you become a professional at repleting potassium. Um, I do this, Anmol, because I know your knowledge base is very advanced, and I'm going to add to it another powerful point to make your life easier. So remember how you looked at that whole exam, Anmol, and you said one word, sympathetic excess, right? Can you imagine, Anmol, when you were a first year medical student, how overwhelming it would be to look at all these things and not know how they are unified by one simple thing? And so I'm going to help you do that with the potassium here. What does epinephrine do to potassium? For example, when you give somebody albuterol, what happens to their potassium?
It decreases the potassium.
Exactly. So in a patient who has sympathetic excess, if the potassium is not low, then you've made the wrong diagnosis of sympathetic excess. You are expecting this potassium to be low because of your pre-test hypothesis of the catecholamine surge this patient has. And so it is yet another clue that a patient has a sympathetic excess. And so further scrutiny of this potassium is likely to be less valuable use of your time because you already have a very plausible mechanism at play. And you only learn this because first you learn how to diagnose sympathetic excess, and then you learn, oh, wow, I don't have to think about the potassium here. And the reason it's important is that you have to be very careful about how much you replete this patient. Because if you replete this patient a lot, then what will happen is rebound hyperkalemia risk. Because all that has happened is that the patient has potassium inside her cells from the catecholamine excess, and once you give her benzodiazepines to reduce that excess, the patient's potassium from inside the cells can return back into the blood. So knowing this mechanism is crucial to avoid over-repletion of her potassium. I think we have a really, really interesting dilemma here that Himon, maybe I can just ask you, how many more aliquots before the final diagnosis? Just I have an idea. Say that again?
One more?
So next aliquot, and then after the next aliquot, we have to guess the final diagnosis. Okay. All right. Wonderful. So I think it's actually a really good time to do a breakout room to start to think through how you would try to navigate a path to clarity for this patient.
Rabih,
Yes.
why don't I give this one more and then maybe
Okay.
I think that'll be really.
I trust you.
Can I do?
Do you think this? Okay, go ahead. No, please.
Yeah.
I have faith in your. Yeah, go ahead.
Okay, so patient was doing well, but then one day later she developed fever, 38.5 with a WBC 13.85, and neutrophil was 72%. And maybe this will add it to more discussion.
Okay, wonderful. Interesting. Okay, I will make breakout rooms. Feel free to chat, and we will take it from there. Oops. All right. Back, everybody. So, Anmol, you've mixed your thoughts with other very smart people. What are you thinking?
Yeah, I think that's a great case. And we were actually discussing about the case we discussed in Academy with Dr. Jeffrey presented about a drug abuse case. And I was the one discussing that. And I think now when I have this new thing in the aliquot, which we have to discuss, that is a fever of 38.5 with, let's just focus on that first. So I think yesterday, I was just telling it in the group, yesterday I was reading up something about it, that we have something called fever that is because of the infections or some pyrogens are released or cytokines are released, which leads to the change in the hypothalamic set point, leading to elevated temperature readings. But then we have hyperthermia as well, which can be due to drug interactions, and it has got nothing to do with the hypothalamic set point. I think it is because maybe, for example, in cases like tricyclic antidepressant, there can be difficulty within the body to dissipate the heat, and that is how they are hyperthermic. Or there are things like serotonin syndrome or neuroleptic malignant syndrome. But I was considering all these things just because I read it recently, and this patient was having substance use. And I think I was with Dr. Austin, and I shared this point with him, and he said that we do definitely expect in drug use cases that hyperthermia comes fairly soon. So since this patient is improving and this patient is also having leukocytosis with neutrophilia, then we can think about other things as well.
Okay.
And I think the neutrophilia can actually represent a stress response too. But to label it as an infection, what kind of infection, that is something we can think about. The patient has so many risk factors for any infection that the patient can have. The patient does not have a home to live. I think an HIV test is anyways important to send in these patients. So if the patient is immunosuppressed, there is a whole lot of infections which the patient can have. But to correlate that infection with this case, that is something I don't have a concrete answer to that. So that is what my thoughts are right now.
Superb thoughts. I completely agree. I'm so glad hyperthermia crossed your mind, but hyperthermia is a constant elevation in the body temperature. And the fact that this patient developed it uh, is a clue towards the fact that it's cytokine mediated. So hyperthermia refers to a fixed elevation in the body temperature as a result of the inability to dissipate heat. And you're stuck. You're constantly febrile. Temperature from a fever oscillates. And so this could be the beginning of hyperthermia. And if the patient's fever stays, no matter what we do, that's very concerning. But the fact that her first temperature was normal is reassuring. It may be an error. Maybe there was a rectal temperature that needed to be obtained initially. So that's possible. So yeah, I think we do our typical infectious workup and ask ourselves, what is this patient at higher risk for? And I think this patient's at higher risk for aspiration, probably, and the subsequent lung injury. Her age and gender put her at risk of urinary tract infections as a result of the shorter urethra and potentially entering perimenopause, the loss of the protective effects of vaginal estrogen. So I would start there and see where the case takes us. It is pretty unusual to develop a fever uh, um, uh, from an infectious process in one day. So it may be possible that she's been infected all along, well before she came into the hospital. But for the sake of time, I'll leave my thoughts as that and see what Hemun has in store for us.
Yeah, so this was a very wonderful experience that I had. So actually, I asked my attending, is there any possibility of infection? And UA, chest X-ray, CT abdomen, everything was normal, and patient was not really showing any pneumonia like cough or any symptoms. So we decided to give just a respiratory viral panel, and chest X-ray was done again, but it was normal. And after receiving acetaminophen, her fever and leukocytosis resolved within one day. So probably from her stress or a sympathetic surge. So yeah, so I like to hear your final thought, Ravi and Amor.
Yeah, what do you think, Amol?
Yeah, I think if the fever is if the temperature is resolving with acetaminophen, then we know that this is fever. And so, so are we solving the infection still, or do we have the final diagnosis now?
Yeah, if you, for those of you who have access to the RLR CP solvers, Reza presented a case to me of an incredible infectious journey. And I'll spoil a little bit of it, which is this very, very sick patient, no clear cause of infection. So many times, either people's infections go away because the body takes care of them. Humanity survived without antibiotics for a long, 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 long time. Remember, antibiotics have been present for 0.0001% of humanity. And so all of us are here because we could fight infections ourselves. So yeah, I think, Anmol, I'll go back to what you said. What is the problem we're trying to solve? And right now, Hemun is creating this picture of a middle-aged woman who had severe sympathetic crisis and is now better. No fever, no white count, crisis under control. It doesn't sound like we have a big problem to solve. And I would say the biggest problem, really, in context, is the interaction of this patient's psychosocial circumstances with the substances that she is using. That's the main problem here. And so there might be a small new problem, but for me, I would keep my focus on trying to help this patient big picture. So I think that in the hospital, there's probably much less problems right now. Going away and discharging from the hospital will require a lot of effort to try to see if we can help the patient. That's where my focus is. But I'm eager to learn from Hemun.
Yes, diagnosis was alcohol withdrawal syndrome with concurrent opioid withdrawal. And very interesting that I learned was a tremor. Tremor is like really, some patient can be like not alcohol withdrawal, but alcohol intoxication can cause kind of similar symptom. But alcohol withdrawal, you really have to look at tremor. So especially tongue tremor is really indication of alcohol withdrawal. So if you are just alcohol agitate, like sedation, then if you give a diazepam, will make patient worse. So always look for the tremor of the patient. And also because the patient had anisocoria, we did a CT head, but even like that patient didn't have anisocoria with alcohol intoxication and with the drug, it has a risk of head injury because of a coagulopathy or fragile vein, or so we should have a low threshold for CT head. And also, when you use benzodiazepine, you can use diazepam. And then also, if you have liver dysfunction, we can use lorazepam. And also, adjunctively, you can use phenobarbital too. So those are things that I learned. Thank you so much for a great discussion.
Anmol, you were wrong about only one thing today. You said Heemoon always brings rare diagnosis. Today, Heemoon is emphasizing and showing all of you how important it is to bring bread and butter cases to VMR. Because if we don't bring bread and butter cases, and all of you will be expert at diagnosing Erdheim-Chester disease, and none of you will be expert at diagnosing alcohol withdrawal. So please, for those of you who are on the edge about presenting a case, on the edge about joining the academy sessions are all bread and butter cases. And so hopefully you can make VMR more real life. And today, Heemoon, you did an outstanding job of that. Anmol, my favorite part of your discussion was how you looked at this patient and said she has too much sympathetic activity. Why? And you essentially cracked the case in that moment by that astute observation. And I also admire how you didn't get too allured to the fever and were balanced and thoughtful about what it represented. Excellent discussion. I'm curious how you feel now and what your reflections are.
That was a great case. And I also definitely urge people to bring bread and butter cases because I don't see bread and butter cases on VMR. And even if then you suspect bread and butter, you don't say it out loud. You're like, no, this won't be the diagnosis. Let's just be quiet. You'll look like a person that they aren't able to diagnose. And no, it's not bread and butter. It's something else. So I think definitely bread and butter is something that is actually the basic. That is the most important thing that makes you a doctor. And I think the rare cases can also be solved with bread and butter. So that is very important. And I love the case, how we discussed each and every aliquot and discussed all the lab abnormalities, the fever versus hyperthermia versus stress response versus drug use, and how it can lead to so many symptoms. Something I wish for the world is like, uh, if I could get off all these the drugs that cause bad things to people. I know when people get onto it, it's very hard to get off it, and then they have to face so many things. So that is something I have a lot of. I am not very. I'm very pained when I see people like that. So I don't know if someday we are able to do something about it. And but yeah, thank you for bringing the great case, and I learned a lot. Thank you so much, Dr. Rabih, for teaching me a great teaching points. Thank you.
Yeah, I completely agree with you, and I love that you're entering the sentiment of trying to be helpful to this patient. And I think you're right that it will take a lot of changes in the way society is set up to help people find meaning, purpose, and joy, and to mitigate some of the very tragic things that happen to people that steer them in the direction to try to use something to make life more palatable and pleasant. But I would say that one thing you can do for every single patient is to actually always, every single patient, treat them with respect. But it's true that when, for example, somebody's family member, say my colleague's family member comes to the emergency room, which has happened for me a couple of times, I will be the first person to admit that I treat them with more respect than I would otherwise. So the average patient always gets respect from me, but a colleague's loved one gets even more respect. And I would encourage you to do the same thing here. By that I mean if you see that somebody is down and hard on life, I think you might consider going a little bit above and beyond in your kindness and how much warmth you exude in the room. And I would say that that might be counter to the urge that society would impart you with, because I think society would probably condition you to be less present, less engaging, less interactive. in a room like this one, but I think the exact opposite might make a very meaningful impact towards a patient. It'll certainly make the chances of the patient coming back to you to seek help much higher than what traditionally would happen. So I would advise you not to add an additional problem to the patient's life, which is to distrust of the healthcare system, which unfortunately is another pervasive problem in these circumstances. So thank you for allowing us, Himu, to talk about all these very common things in our lives, and I'll pass the mic to Hans to summarize the judging points.
Yes, thank you very much, Himan, for this beautiful case that, as a matter of fact, we see so often in our hospitals, at least the little county hospitals, we have them quite often. Thank you. We had a patient in her 40s who presented herself with anisocoria, visual disturbances, as well as hallucinations. We thought about anisocoria. What could it be? It was in one eye, so it was focal, and that can be due to any localized problem going on in the brain. We took a CT and ruled out that there are any lesions in the brain. If it is in both eyes, then we are thinking about medications, something more systemic, medications and substances that could be abused. Patient also presented herself with hallucination, and here we have our altered mental status, missed mnemonic, which is metabolic, infection, substance abuse, and trauma. In this case, looking at her history, we see that she was abusing cocaine, methamphetamine, opioids, and alcohol over a long period of time. So now we have polysubstance abuse with a sympathetic excess tone. And the symptoms themselves, like sweating, feeling hot, tachycardia, already give us an idea what substances could be at play. Here it probably was cocaine and methamphetamine who caused her this sympathetic excess, as well as the possibility of alcohol withdrawal. The physical exam showed that her anisocoria was almost negligible. So we focused on the polysubstance abuse. And here we had cocaine and alcohol withdrawal as being one of the top culprits of her symptoms. The electrolytes and labs showed an AST elevation. And here it is the question, is it the liver? Does it come from other organs in the body like muscle, brain, or kidney? And the GGT would give us clue of where it might come from. We also saw hypokalemia, it was 3.2, and this is can be expected in a patient with excess sympathetic tone, as adrenaline drives potassium back into the cells. While we were treating her with benzodiazepines, and that is a very safe treatment under such circumstances, we have to keep an eye on potassium, as this might then increase again. Patient later on developed some fever, and then again we have our IMAID mnemonic for fever, and in this case it was a question, is it infection? But she developed it within the hospital, so she might have had an infection either from outside, less likely maybe from the hospital because it occurred very fast, or is it drug withdrawal? And here we have certain medications that can cause hyperthermia, such as the serotonin syndrome or the neuroleptic syndrome itself. So here probably, again, alcohol withdrawal as a possibility for hyperthermia, the inability of the body to dissipate heat, which is to be expected under sympathetic tone. The diagnosis was a complex interplay between psychosocial circumstances leading to substance abuse, and substance abuse again influencing psychosocial circumstances. Thank you very much. It was really a beautiful case. Thanks.
Awesome. Back-to-back teaching points at times 2, and your reps are showing. Thank you for a crystal clear summary of the learning in this case. Guys, it was a real treat. I already look forward to the next time. See you soon.